what we were talking about today. I'm working on it at UNSW. I'm doing one there, and it's in an unrelated area to what we do here. But the method is really cool, and so I thought it was totally relevant for us here because it is about whether you can use observational data to recreate an RCT. And so I think we can benefit from that. But what I've done is, instead of using my own work, I'm using a case study that I read about using biologics for asthma. So it's related to what we do, but it's more what you guys do than what I do. So if you think I'm saying something completely stupid, please just say, no, Brian, you've got the wrong end of the stick. Or there's some other research around that I might not have picked up on. So I'm very aware of that, but I might as well make it relevant for you guys. And the other caveat is that I really like the slides with the blue leaves and the lemons, and they have, as I was telling Amber, they have nothing to do with the talk. So they're there if you are bored and you can just look at lemons and think about being in Missouri or something. So we started this. So this is how I think about a target trial emulation. So if an RCT is like our highest level of evidence and it's our gold star, our gold standard, and observational data, which is what I usually do, is kind of like approximating that, but it's a bit sketchy and we get some knowledge, but we obviously get a lot of bias and confounding. Then a target trial emulation is sort of better than just a normal observational study, but it's still not gold star. It's kind of on the way there. So that's kind of, I think, the best way to describe it. So why would we use a target trial? We'll get on to why and what it is. So we would use it if an RCT is not ethical, feasible, or practical, which is often what happens with the stuff we're doing. Or if we want preliminary evidence to support running a clinical trial. So we can actually get some evidence. But what is it? First of all, it's not an RCT. It is still observational. It's just a bit of a shinier observational, more yellow, like the picture I showed you. It uses existing data. It basically emulates a clinical trial RCT as closely as possible by pre-specifying all the components, and I'll show you the example of that. It more accurately specifies time zero eligibility criteria follow-up than the traditional observational cohort studies. And it helps to reduce a lot of the biases, but not all of them. Oh, and actually, if we go back to that, has anybody read papers? Like, have you come across emulated target trials where you're like, what are they talking about? Has anyone come across them at all? Is this like, no, completely new, never seen this before?
Yeah.
Completely new to you?
I think, sorry, I've heard of it mentioned.
Yeah.
But people want to do it.
Yeah.
Would we do it?
Yeah.
It'd be good to do it.
Yeah.
Yeah.
And Dennis, you've heard of it, haven't you?
Yeah, just heard about that one. But propensity matching is the one most more of this.
That propensity matching is one of the things you use within this.
Yeah.
Yeah,
Okay.
it's part of it. Mike, have you come across it? Okay, no. Okay, all right, okay. So, yeah, all right, well, that's good to know. So last year in JAMA, these particular authors put together a checklist called the target statement for target trials, so that if, it's like what we use in other types of trials or cohort studies, we use strobe and MOOC and all the different checklists. They've just created one for the target trial so that there is a point of reference that everyone can start using. And in this list, the important person here is actually the third author, McLaughlin from Harvard, who's the guy who actually came up with the target trial emulation. So really, all kudos to him. But what is noticeable about this list is the beginning part, abstract and intro, and abstract and intro is just the same as any list we would have for any study we were doing. And results, discussion, and other information is fairly standard. We do for any other study, RCT exhibition. It's this bit in the middle, that the methods part, which is the target trial part. And the important thing about doing a target trial is that you basically create a table as this is before you start your study, and on the left-hand side, you write down how you would do it as an RCT if you were doing an RCT. If you could do your ideal study, what would you do? Right? Like, assuming ethics doesn't matter, nothing matters, right? How would we do it? And then over here is your emulation. So this is, okay, this is how we are going to approximate it using observational data. Now, some parts, as you can imagine, I'm probably already thinking, are a lot easier to do than other parts, right? So like off the top of your head, what do you think is like really hard to do in an observational study that you're doing in an RCT, but you can't really do it with observational data?
placebo controlled arm.
Yeah. Yeah, exactly. I mean, placebo arm can be really hard. What else could be difficult?
No combination, like bias,
Say it again.
there is bias, like confounding factors.
Yeah, but in the actual design, like what's the obvious thing that you can't do?
Randomized.
Exactly, you can't randomize. If you're using data that already exists, like if I take it from hospital data records that I have, I can't randomize people, right? So that's kind of one of the issues that you're trying to get around this. So I've just pointed out here, I put this as the same table again, but I've just marked where the points are that I think where the target trial sort of helps compared to kind of, because most of what I do is observational cohort studies, right? I don't do RCT. So for me, what it improves for me is here in the eligibility criteria is really deciding who you want in your study. And sometimes I think with other observational studies, we kind of take whatever we can get, but this eligibility part is really going, well, if you did a trial, who would you start with? What would your inclusion criteria be? What would your exclusion criteria be? Okay, can you emulate that within observational data? And I found last year I was doing a study where we were looking at asthma in pregnancy. And normally we'd just take any woman that had any asthma medication during pregnancy. But when we thought about it like this, we went, wait a minute, no, they need to be eligible to be in our so-called study, which means they need to have asthma at the beginning of pregnancy, not anytime during the pregnancy. They have to start with asthma because that's what we're interested in. So it's changed the way we were thinking about it. Assignment procedures, that's what you were saying, Joy, about randomization. Difficult to do, but we'll talk through that a little bit. Follow-up, also really important again, how are we following them up in a RCT? And again, I can give the example of my pregnancy study. If we look at asthma in pregnancy and let's say we want to know the outcome in the child, we want to know if the child gets asthma, when do we set time zero? When do we say the woman is randomized to asthma or not? When do we look at the outcome? Like it is tricky because really it's an after pregnancy thing. Whereas like if you're doing your RCT, the time zero is when you give them the randomization. So it's thinking through that, like when are we randomizing and when does our time zero start? And I know Miguel Hanan says a lot, you've got to really align those. You've got to align the randomization and the treatment start to when you're starting follow-up. And a lot of bias in observational studies comes because people don't align them. And you get these things called like immortal time bias and selection bias that throws off the analysis without people realizing. And the other one is identifying your assumptions. So there's a lot of, the main assumption in an RCT is that your treatment or your intervention, your control are equally balanced, like in terms of confounding. That's why we do it, to get rid of confounding. But how do we achieve that if we haven't been able to randomize? So we have to specify assumptions and again, think about how to get around it. Any questions before I keep going to the example, which is the next thing that I'll do? It's probably better to show you 5 examples. So we're going to look, as I said, at this study, which was in Jackie 2023 by Akenroy, and it's about a comparative effectiveness of omalizumab, mepolizumab, and dupilumab in asthma, a target trial emulation. So the question was to compare the effectiveness of all 3 in reducing asthma-related exacerbations and improving lung function in individuals with asthma. And their rationale was that at the time of their study in 2021, when they started, there were no head-to-head comparisons of any kind for biologics. So they figured that it would be good to try and do a target trial emulation and get some data out there. Right? So if we start with this is the table again. So for eligibility for their study, they decided that people have to be over 18. They have to have a diagnosis of moderate to severe asthma, where ICS hasn't worked in combination with ARB, and or on maintenance OCS. And importantly, that they kind of had a map in the last year, right? That seems reasonable for an ICT, I assume, because you want to have like they haven't been using it. And they excluded people with other types of lung illnesses. Does that seem reasonable to the ICT people in the room? Yeah. So then to emulate that, what they did is they said, okay, we're going to keep this bit is exactly the same as this. That's who we're getting 18-year-olds. They have to meet these criteria. And they took them from this data registry that they had already. And then they restricted to patients with clinical equipoise, if that comes with, and eosinophil count. And the reason they did that is because that's, according to them, the criteria for what gets you in that. So they're like, well, we'll make sure they're within the criteria of what would get you to be prescribed in that, right? And then, but like, in my opinion, and if you're doing that, you would probably, well, maybe you wouldn't do that here. Maybe in ICT, you wouldn't look at that news, but I don't know, I'm not sure. That's when like clinical expert.
Well, this is a bit like Peter Walk's choosing between the maps.
Yeah.
So
Yeah.
they compared MIPO and omalizumab
Yeah,
in patients that were eligible for both under the PBS. So they met the biomarker criteria for both.
okay, so it's like, that's the same, yeah.
Yeah.
Cool. And then that's the same to receive the map, and then this they've excluded, but this one is interesting because they've excluded other people because they may have been given a map for these things, so they wanted to make sure they weren't given a map for that. Whereas I think in an RCT, if you've divided them in, if they have asthma and they've met this criteria, you might go, well, we don't care about this because we're not giving them the map for this reason.
Yeah.
So that I find interesting. I mean, that's what you have to do, but it's interesting. Is this now biasing your study? Well, it certainly makes maybe not as generalizable, but that's interesting.
Yeah, because those are off. A lot of those are like type 2 comorbidities.
Yeah.
They are often analysed within the large clinical trials as like, some populations that respond better usually.
So that's what I mean. It definitely then makes it less generalizable, doesn't it? And you can't do that subpopulation because you've taken these out.
So they're saying that they just have those conditions that they have those conditions, or that they have received in the past a biological or one.
No, they haven't received it.
Yeah, okay.
They
So
just,
that-
but like they're going, well, they have this, how do we know when we look forward at their map that they didn't get it for that? Like,
So they can't tell.
no, let's assume that there's no indication data in
Oh, okay.
information in
So
there,
there
which
is,
there often isn't.
yeah.
So
So they're just making sure that what they got the biology for.
was for asthma and not for these other things.
Yeah, okay. Yeah.
Yeah. So then this is who they had, just to make it so you know. So they started with 1,024 people who had severe asthma and had a map at some point. And then they basically exclude based on the things we said before, like these are the ones that have those alternate indications we just talked about. There's a whole bunch, like 446 come out just because they don't meet those criteria we said before. So that means, I'm like, well, that means people being mad that don't meet that criteria, which is interesting. And this is what they get left with. It's not very many, but that's the study. And then treatment strategy and assignment. So in the trial, these are your treatment arms, and then that's the same in the emulation. Like you're just looking at, did they get one of these three, right? Then so normally if you did an RCT, you do a random blinded assignment to treatment arms. So obviously it's not blinded, that's just how it is. And then obviously they can't randomize either. So what they've said is we base it on the monoclonal antibody that the individual received, which is obviously decided by the doctor. And then what they do is they apply overlap weighting model, which is essentially a propensity score method, to the covariates to try and balance it. So this is kind of like a more fancy version of what we do when we adjust or deal with confounding, but essentially it's just weighting, adjusting for confounding using a baseline variable. It's nothing super special. This particular method they say is better than other methods, but it's not a target trial thing. Specifically, it's just a method.
So it's not picking a subpopulation that match really well, it's just adjusting for the differences.
Oh, it could be, I don't know, I didn't read into it, it might be,
Yeah.
like, and that might be why it is a better
Yeah.
method to use, but the point is, we could do this in a normal
Yeah.
study, it's not public trial specific. They just often do, they seem to use a lot of propensity score matching, I've noticed in target trials.
Yeah, there's a propensity score weighting, I think individual get a weight based on the matching.
Yes,
If
yeah.
more matching, more weight. If
Yeah.
less matching, less.
Yeah. So it might be that it lends itself better to target trials, but I don't know, like, something I need to find out. So then time zero in this case for your target, if you did it as an RCT, it's when you're randomized, and what they did is they said it's the date of initiation of the monoclonal antibody therapy, which in this case is handy if they know the date. When stuff like we've done, like if it's asthma or asthma, there might not be a date. So it's not always, it just depends what you're doing, but it's definitely, as I said, really important if you can have a very clear defined time zero. So it does lend itself well to Medicaid and pharmaceutical type trials. Questions, not so well, for example, to a natural experiment, bushfire, no bushfire, it's not that great. Follow-up, they did 12 months from time zero or the end of the study period, and for the emulation, you do it the same way. It's not that hard with the data. And then for the outcomes, they looked at an annual asthma exacerbation rate, a change in FEV1, and the time to the exacerbation. That's fine, they could get all of that from the data that they had. So they said that's all standard. And then for the causal contrast, if you're doing RCT, you'd like to do an intention to treat. And they're saying that that's what they're doing as well. I guess they are, as long as they're doing. I've lost to follow up, but then you have lost to follow up here, so I guess it's the same. Then the assumption is that, as I said before, the covariates are balanced between the groups and there's no confounding adjustment required. Like that's our normal standard doing an RCT assumption. So in the emulation, it again comes back to this overlap weighting conditional baseline covariates, that the assumption is that this is going to work and balance the covariates and we won't have any residual confounding, which we can't really assume that, but that's the assumption that I think. And then for the statistical analysis, essentially it's the same. Except they add this propensity score weighting in, and then they do a bunch of sensitivity analyses, which is exactly what I'm doing right now in mine, because we can't do the perfect trial. We do have problems with confoundings, so we have to put in a bunch of things that will help us to at least assess that. And that's not unusual for an observational study. But what I think is better with a target trial is that it helps you to, by doing this process of thinking it through beforehand and writing down, okay, this is what I would do for the perfect trial, and realizing where your gaps are. It helps you to design your sensitivity analyses to try and address the gaps. That is what I found, and I find it really excellent because I can't know the perfect answer, but I can at least get closer. And the other things that I found happen a lot in target trials is they use cloning, which is, I won't go into it, but they basically put everybody into the treatment site and everybody into the control site, no matter which one they were actually in. I don't get how it works because I haven't done it yet, but it seems to help. And then they also weight for censoring. That means that they put a weighting on who actually dropped out because that can affect your, that can cause selection bias. So they put like a propensity score around if you would be likely to drop out or not. Which again, these steps we don't normally use in observational studies. So I think they're, again, advanced methods that have come in through people trying to really get this target trial done. But there's no reason we couldn't apply them to observational studies. So this is the results that they found in their target trial emulation. And essentially this is your exacerbation rate. Here's your 3 drugs, and it's showing that the dupilumab has the lowest exacerbation rate, so it's the most successful in this particular study for the number of people they have. Right? So, yeah. And then I found this study or this analysis by Brian Lidworth from Allergy. It's a head-to-head comparison of biology efficacy in asthma. What do we learn? And all of these are observational, right? So Acamode, what you just did here is there at the top, and there's the results of the dupilumab and the MEPO showing the red dots are where it's significantly different. And then the other ones I've marked are the ones that just looked at the exact same drug. So everything else is using different drugs. But if we just directly want to compare, what did they find when they did the target trial compared to Bateman et al., who did an indirect comparison, and Bleeker, who did a retrospective cohort? And you can see, like, they are actually similar, but they have the target trial actually got a greater result. And I was talking to Dennis earlier, so indirect comparison, I didn't know what that was until about an hour ago. Does anybody know what that is as a study type? So what it is that it's actually a meta-analysis where they get a bunch of RCTs together, but the RCTs don't compare the MABs against each other. They compare MABs against ICS. So they've got ones for all the different MABs and ICS. And then they go, oh, look, MEPO is much better against ICS than dupilumab from a different study is against ICS. It seems super dodgy to me, but apparently it's a thing, and there's a special method, Beaker's method or something, that puts it all together. So I hopefully by using a target trial, we are advancing from that method. And then the retrospective cohort's just that, like they've used a big US directory. But what you can see here is the confidence intervals are really wide because they didn't have very many people in their target trial, whereas these guys, they had tons in their US data set. So swings and roundabouts maybe. And then the only study I could find that was actually an RCT of these drugs, and that's why I was asking Dennis if you knew of another one, is, so if there is another one, you can tell me, but this is all I could find was patients with chronic rhinosinusitis with nasal polyps and coexisting asthma. And they were in a trial, a randomized trial for dupilumab and omalizumab, and these are the lung function and ACQ results. They had very few exacerbations, so they couldn't look at exacerbation outcomes. But again, I mean, at least it's saying that the dupilumab is better. So.
Is that just between MABs efficacy trial? Not inferiority. I don't know.
Has he published that?
No.
It was presented at ERS.
Yeah.
Is this the one you were just talking about?
It was.
Yeah, that's what
Yeah.
I was.
I can't remember.
Lau did publish some stuff on his.
Yeah, he did some ILC stuff and yeah.
So we're still waiting for that.
I think this was a non-inferiority trial, didn't it show they were no different from each other?
Yeah.
Right, so all the observational studies, the target trial, and this using maybe different patients is showing that it's showing how bad exacerbations.
Oh, yeah, I can't remember the study size. It would have been on the smaller end, I guess, yeah.
It was like about 100 or something.
Okay. So just points of discussion. If you're considering the target trial, I would definitely tell you, advise you to use the target checklist in that paper I suggested, so it tells you how to do it. You essentially need to create a table that's showing you comparing your hypothetical trial and your emulated trial, and consider pre-registering the protocol like you would do for an RCT. So that's what we did with our one at UNSW. We put it in OSF bio, which I think is cool, except the person I'm working with keeps saying, you have to follow the protocol. And I'm like, oh, okay. So, can't we just change this? No, you have to follow the protocol. And it's just like, that's the point of it, right? So it's been a really interesting learning experience. And then the advantages are that it forces you to pre-specify the parameters of your plan, like really pre-specify. And it reduces bias, particularly selection and the immortal time bias, and it puts transparency around where your limitations are, which helps with planning and sensitivity analysis, as I said. Disadvantages is it doesn't really overcome unmeasured confounding any better than a really well done cohort study. And it's not always applicable. You can't use it in every situation for sure. So that's my conclusion, the same as the beginning, is that's what I think and that's pretty much it. So, oh, and when I fix them up, I fix up. So does anyone have any questions?
Yeah, quite often when these indirect comparison or similar drug trials studies are published, then there'll be like responses criticising the approach,
Yeah.
presumably promoted by whichever company came up with worse in there.
Oh, yeah.
I'm just wondering were there any responses to that particular article that you presented?
Do you mean?
Sort of editorials or comments?
Do you mean this one, the head-to-head one, or do you mean this actual?
Your target trial that you.
The one with the 3
The
maps.
3 maps.
Oh, this one?
Accurately, was it? Yeah.
I don't know. That's a good question.
Yeah, and also what is their conflict of interest?
One of them definitely has a conflict of interest. I think it's this one. They definitely, but that's good. I just happened to see that when I was looking for it, but it wasn't something I was looking for. Yeah, I don't know. Good question. Worth considering, huh?
Yeah, just one second, because sometimes they'll have an expected economy analysis or some of the potential caveats or.
This one, that they definitely had responses. So, which would make sense when if they were sponsored by the company and then they're trying to present an RCT. Any other questions? Questions from anyone online?
Hi, Bronwyn. I have a silly question, if I may. Yeah, I'm just wondering what the literature review in general they say about the use of RCT with observational data, and can it be used for any other diseases apart from lung diseases? I'm just wondering because the reason I was asking is I'm dealing with treatable traits and I have no idea what it was. When I read the literature, there's really general support of the traits. And the reason why they were supporting that is because it is something new. However, they were asking for more RCT in general to convince them more. Now, my question is this type of RCT has the same level of acceptance in general in literature? I'm just curious because I haven't heard this before. Thank you.
Yeah, no, it's not as strong as an RCT. That's why I had the picture of the stars to kind of show us it's getting there, but it's not there. But so I think it depends, as I said at the beginning, if like sometimes it is not ethical or feasible to do an RCT. So then this becomes the best thing we have at the present moment. And a lot of things I do are not. You can't, put RCT over cliff fire. Like, so, and the approach that we do at UNSW, we're looking at women who had an induction versus women who didn't, and you can't ethically put women into an induction group on that. So there's lots of things where it applies, and I think it does look on the best thing we have. Kind of, unless someone comes up with something even better, don't think we'll get better, but it's also like, I think, RCTs are really expensive and hard to get the money for. So if you can do this to at least present the best observational data you get to then justify why you should do an RCT. But we know that lots of observational studies have led to RCTs that are showing nothing. That's a really common phenomenon. At least this could maybe help strengthen, it's likely that our RCT will show something.
Yeah.
So it would be good if Peter published that study, because it would be really good to put that in the bucket with all the other ones that are going on.
Yeah, they must be trying to publish it.
Yeah.
Yeah. Any other questions?
I thought it was interesting that they ended up because I would have thought the advantage of doing the real world study trial emulation is that you get a broader population, because a lot of the clinical trials that are often criticised because they don't.
They really are too.
Yeah, so only 20% of people coming through a severe aspect these criteria, something along those lines. So that they then excluded a bunch of people that would have type 2 comorbidities, which are really frequent.
And actually, at the one I'm doing at UNSW, we've also done tons of exclusions. So that is a really good point.
So that makes it quite different than from a real world observation study.
Yeah, that's why it's something in the middle.
Yeah.
Yeah, we actually did a recent publication, but we actually choose the control group, not like a propensity matching or anything. We just looked at the baseline characters and tried to match the baseline characters.
That's good too. I think then you have to, if you're thinking like that, like we want it to be generalizable, you have to be just really thoughtful about, should we exclude, why are we excluding? In the one I'm doing, we excluded for fairly similar reasons, in that we wanted to get rid of the indications for induction, because basically our project is about whether doctors are just giving them too early and too many. So we needed the indicated. So depends, I think. But I suppose another way they could do it is they could do a sensitivity analysis where they put everyone back in and go, look, well, what happens if we do generalize this and we go, right, we're going to not worry about these cut-offs and we're going to put those people back in. If it was me, I probably would have done that actually. Because if you find the same thing, then it's like, well, look at our results. And if you don't, then what does that mean?
Yeah, that's the question. They might have done, and if there are no significant result.
You always got to be careful what
I guess maybe if they don't, because some of the drugs get dosed differently depending on the indication, so that could be a factor. If they don't know, if you get twice as much drug for atopic dermatitis as if you were.
Yeah, and but also they had the cutoff of the IgE and the eosinophils, but not like in the registry data I use, we don't even have that, and we wouldn't even know that. Like if we wanted to do this kind of study.
But if it is biology registry,
We always have.
we always have
Because
that.
that would be part of the criteria.
You haven't,
They don't
You
get that
can't
treatment
treat
without it.
without.
Yeah.
but if you were just choosing it from if you did this based on the pharmaceutical benefit scheme data that you would get from AIHW, for example, if you wanted to do this, they wouldn't tell you that.
Probably not, but in theory, they would got it.
Yeah, really, they are all about, because then only they will get that medicine.
Yeah.
Okay, or you make the assumption that they all met
They
the
all met.
criteria.
Yeah, that's assumption, right?
And if that is a rule in Australia, but obviously it looked like a heap of them in this study, which is from the US, that they have been given it who didn't meet that criteria, or maybe that data was missing and so they just weren't retaking that, I don't know.
Yeah,
Yeah, the criteria for the new verification.
Yeah.
yeah.
Anyway, so we'll leave it there and thank you for listening. Okay. Okay. Are we finished early?
Thanks. Online, everyone. Bye.
Voice block.